Good afternoon, everyone online and in the room. Appreciate you joining us for our grand rounds on improving physician communication. My name is Chuck Barris. I'm the Chief Medical Officer here at McNeil, and I'd like to introduce our speaker for today, Dr. Sadia Ghazi, coming to us from the Medical Center. I'm not going to go over the whole CV, but I'll give you the highlights. Dr. Ghazi did her medical school training in the United Arab Emirates, and then came to the States where she was a resident at Griffin Hospital in Connecticut. Prior to that, she was also a research associate at Johns Hopkins. Then she completed her residency training at Griffin Hospital in Connecticut, and then she was with the Yale Health System for a few years until coming to Loyola in 2020. And she has a special interest in physician-patient communication, and we're lucky to hear her today. Dr. Ghazi, thank you.
So, thank you for that introduction. This is, for the last 2 years, I've kind of been working as the lead educator in physician communication at the medical center. And this really started 2 years ago as a passion project. Any quality improvement study that I have, project that I've worked on has always been with the theme of improving physician communication and patient satisfaction. And we've actually turned this project into an actual curriculum, which we hope to be sharing here at McNeil and Gottlieb Hospital as well. So let's go ahead and begin. Oops, this is not moving. Oh, here we go. Not moving. All right. So before we start, I do want to make sure we talk about, why is it so important that we talk about physician communication in the first place? Well, we have to admit, not all of us are good communicators. It's not a skill that comes naturally to all of us. So there is opportunity to learn. And then we got to remind ourselves, what is our job description? As physicians, this is a people-person career that we've chosen, right? We are talking to people all the time. We're talking to patients all the time. But different from other people-person careers, in our particular people-person career, our patients' lives literally depend on how we communicate with them, right? The patient's health is on the line when we communicate. Communication is not just words. A lot of other things go into communication. The word choice that we use, our emotions, our facial expressions, our body posture. So I want to go over a lot of those things. And there are ways, if you learn and practice and get deliberate feedback, there are ways you can make your communication more efficient. And how can we forget, public reporting scores always include patient experience metrics. Patient experience is tied in directly with how our physicians communicate with our patients. Nope, it's not working again. There we go. All right. And at Loyola Medicine, how can we forget? We treat the human spirit. So we're going to be treating the human spirit. We got to get on board with how can we communicate better. Very quickly, I know we've got a lot to cover in the next hour. Let's go very quickly over our mission, vision, and core values, right? We serve together in the spirit of the gospel as a compassionate, transforming, healing presence within our community. Our vision is to become a national leader in improving the health of our communities and each person we serve. We want to be the trusted health partner for life. And our core values are of reverence, commitment to those who are poor, safety, justice, stewardship, and integrity. So if I was to ask around the room, right, and you guys can just shout out answers, what is the most common procedure that we perform? Okay, and mostly I think we have mostly internists here today. So what's the most common procedure that we perform? Blood draws. Okay, so usually I'll get NG tubes, right? Blood draws, ABGs. But if we were to think, we always think of procedures as something we do manually, right? But the procedure, right, the definition of a procedure is the way we do something, right? There's a beginning, there's a middle, there's an end. So if you actually consider the patient encounter as something we do, beginning, middle, and end, that can be considered the most common procedure that actually unites all of us as physicians and surgeons and providers, right? So how many patient interactions do you expect to have in your entire career span? Can anyone kind of guess? So on average, in a 40-year career span as an internist in a primary care position in an office, they would see at least 200,000 face-to-face patient encounters. And that doesn't go to say, the other patient encounters you might have to have, or the other face-to-face encounters you would have to have with family members or consultants or the nurse or the office staff for that same patient. Yet, how much training have we received in actually communicating well? Right? So somebody taught you, like, hey, this is how you do blood draws. This is how you start. This is how you end. Somebody taught you how to place central lines. Somebody taught you how to place NG tubes. But if you think about it, if you go back to your residency or medical school, how much feedback did we ever get on that interpersonal skills, on that face-to-face communication? So communication is something we need to know. It's okay if we don't have it naturally. This is something that can still be learned. It's a performance that can be enhanced, and with deliberate practice and feedback, you can master the skill. And studies show that communication skills training for physicians improves patient satisfaction. So who benefits from us improving our communication? Well, first of all, patients, right? Studies have shown physicians who have good communication skills, their patients have better A1C scores, their blood pressure is better, their pain is managed better, they adhere to medications, they're more satisfied with their care experiences, they feel more relief of their suffering. In fact, there was a study that showed the benefit of a good patient-physician relationship was as beneficial as a daily aspirin in preventing myocardial infarction. So when you take that extra effort to communicate well with your patient, think, I am giving my patient their daily aspirin. Not only patients, but healthcare professionals. You guys benefit when we all communicate better. There's better engagement, satisfaction, workload stress. Less likely a patient will sue you for malpractice when you've communicated well with them, even if there are complications, and better team collaboration. Institutions better from improved communication. Your Press-Ganey scores, right? We're always talking about Press-Ganey and HCAP and our patient experience metrics. These all are directly tied to improved, better physician communication. And the questions that patients are asked in the surveys when they go home, I've put them up here, but how often do you feel your physician has treated you with courtesy and respect? How often did your physician listen carefully to you? How often were things explained in a way you could understand? So these are all questions that patients get asked. Due to time, I'm actually going to just go very quickly over this slide. But we always talk about value, right? And sometimes we think of value as, okay, outcomes over cost. But as we move into more value-based care, we have to take patient experience into account. And so the numerator actually changes to outcomes and experience. You can have great outcomes, but if your patient never felt that they were well taken care of, if your patient didn't truly experience a great time, then your value still decreases. So we have to make sure that we're incorporating experience into that equation of value. So before we begin, let's talk about this quote by George Bernard Shaw. The single biggest problem in communication is the illusion that it has taken place. And so a lot of us might think, hey, yeah, I talked to my patient about the side effects of the medications. I gave them a good discharge instructions. But again, if we don't approach our patient encounter as a procedure, we assume that our patient understood the instructions we provided them. We assume we communicated well, when in fact the patient didn't walk away with much information. But as I speak, many of you might be thinking, oh gosh, but we don't have time. We don't have time to communicate. We don't have time to sit down and give details to the patient. The point is for you not to waste time. The point for me to speak today is to make you more efficient. And actually, there are studies out there that show that physicians who address the emotional cues actually ended up saving more times with their visits. They compared a group of internists and surgeons. And in both categories, they saw that addressing emotional cues, making empathic statements actually made physicians more efficient. So what is it we're going to talk about today? I've divided all the skills into blocks. This is how our curriculum is set. And each block is actually some educational conversational tools that you would be taught on a monthly basis. And I'm going to go over everything really briefly in the next hour. But this is pretty much how the curriculum is designed. And if you want to, you could think of it as bookends, right? So you've got a little bit you need to do in the beginning and a little bit you need to do in the end. And then the books, we just got to rearrange it a little bit. And, when you're in medical school, you learn your clinician clinician-directed history building skills. These are your typical, right? Where's your pain? How did it start? How severe is it? Give me a number. What makes it worse? What makes it best, right? We've learned this in medical school, but the hope is that we can actually shorten that duration and add in a little bit of the skills that I'm going to teach you, and that will help sort of maneuver you into your clinician-directed history building skills. You end with a physical exam, and then your last skills are, oops, this is going a little too fast, educating, counseling, and planning. So we're going to talk about all these skills. I do want to mention a little bit about eye care. I don't know if you have heard about this yet, but this is definitely something that we are pushing with throughout all the Trinity hospitals. Eye care stands for introduce, care, ask permission, reduce anxiety, and exit with reverence. And the goal here is for us to, throughout Loyola, improve patient safety, clinical outcomes, and enhance patient experience. And hopefully, if I finish quick enough, Anita can touch base a little bit about our eye care initiative at Loyola. All right, so let's begin. We're going to go over these skills. The beginning is pretty easy, right? So first, you want to start with preparing yourself. You're going to be like, oh, this is easy. Of course it is. Before you enter a room, rather than just entering a room without a plan, have a plan. Go over your agenda. What is it that you need to talk about with each patient? Is it, oh, I need to talk about the labs we just got this morning? Is it, I need to talk about the abnormal vitals this morning? Quickly go over your phone, have an agenda set in mind. Take a deep breath, know what you're going to say, and then walk into the room. Of course, before you enter the room, ask permission. So you want to knock and you want to ask permission. Oftentimes the curtain is pulled. Patients are, patients could be, they're possibly being cared for by the nurse. Ask permission. Hey, is this a good time for me to come in and chat with you? Then we're going to talk about how we can create rapport quickly. This is probably the most important part of this entire lecture, and these are the things I'll go over real quick. So how can I walk into a room and immediately, within the first few moments, not minutes, first few moments, the first few seconds, how can I create rapport quickly? We'll start with a welcoming statement. Right? We all know this. We all know how to be nice and polite. Start with a welcoming statement. It's a pleasure to meet you. Very nice to meet you. Good morning, good afternoon, good evening, whatever it is. I do want you to, however, avoid asking a question like, hey, how are you? Right? So oftentimes this is very common, it's almost habitual for us to say, hey, how are you? Hey, how are you? Right? To our family, to our friends. But what's the problem if you walk into a patient room and the first thing you say is, hey, I'm Dr. Ghazi. How are you? Has that ever backfired for anybody? Right? Yeah. What's their response? How do you think I am? I wouldn't be in the hospital if I was okay. So asking a question right off the bat as you enter a room can often backfire. And the other thing is, as soon as you say, hey, how are you? Oftentimes they'll go straight into their problem list, right? They might start with, oh, yes, I'm having chest pain. It started 2 days ago. And you don't want them to go straight into their problem list. You want to wait a few moments to create rapport, give you a chance to create some rapport before you dive into their problems, right? So any kind of welcoming statement is great. Short and brief, but just avoid the questions. Why? Because you want to make sure you save those few seconds to create rapport. Utilize the patient's name. It is so awkward when you walk into a patient's room and you say, hello, Mr., and then you got to pull your sheet out and remind yourself what the patient's name is, right? So prior to going into the patient's room, know their name. Speaking to a patient using their name gives them a sense of importance, makes them feel secure, like the doctor knows them, and the patient will more likely remember that encounter if you utilize their name. And of course, if appropriate, I know post-COVID, many of us might still feel icky about shaking hands, but hey, if it's appropriate, go for it, right? It speaks to your character as a person, and it indicates the beginning of a trustworthy relationship. Now, small talk before big talk. So before you dive into the big information that you want to share with the patient or obtain from the information, allow some room for small talk. How can you do this? Make a brief personal connection. Talk about something generic. Maybe the weather. Maybe it's really rainy outside the window. You can comment on that. Maybe it's really beautiful and it's really sunny. Talk about that. Talk about something in the room, flowers, pajamas, whatever the patient's wearing. Something you already know about the patient. Perhaps he loves golf or he likes tennis. Talk about that. Maybe you know about their family member, their grandson, perhaps just graduated high school. So make some small talk before you move into the big talk. So we have this gentleman here. If I don't know this patient, I'm just walking into his room, what are some things I can comment on to make some small talk before I talk about bigger information? Just shout out. Anything? You're dressed this morning. This man is dressed. He is in his street clothes. He wants to get out of here, right? Comment on that, right? You can say, God, it looks like somebody really wants to get out of here, right? Small talk. What else can I comment on this patient? He's reading something. He looks really engrossed. Wow, looks like you're reading something really interesting. Talk about that, right? What else can we comment on? You see flowers. Who visited you? Those are beautiful flowers. Anything brief. We're not talking about minutes and minutes of conversation. Few seconds, a few moments to make a brief personal connection. So small talk before you dive into the deeper talk. And then sitting down, right? We say this all the time. Sit down, sit down, sit down. Evidence, this is evidence proven, right? Associated with, sitting down is associated with more improved patient satisfaction scores and a perception that the physician has spent more time with the patient. Sometimes there are no chairs, like in the emergency room, at least at Loyola. Sometimes we don't have chairs, but we can still look relaxed, right? Lean against the wall, perhaps sit on the bedside by their feet. Any way to show that you're relaxed and try to get like eye level to the patient is always great. Then turn off the distractions, right? Set the stage to listen. So if their TV's blaring, ask their permission. Hey, is it okay if I turn off the TV? This sets the stage for you to listen, but it's also a sign to the patient like, hey, you got to listen too. I'm here to listen. You need to be here to listen as well. Not just turning off distractions in terms of sound, but let's say the patient's like lopsided on the bed, help them up a little bit, plop them up, fluff their pillow. Maybe they're eating breakfast. You can cover their tray. Remove all these distractions so that you are setting a stage to listen, and they also know that they need to be listening too. Then provide your introduction, right? When you provide an introduction, hey, I'm Dr. Ghazi, let me examine you. Doesn't work, right? Who are you? Who is Dr. Ghazi? Why are you in my personal space? And why are you asking me all these questions, right? So give them your name, state your name. What's your team? Okay, which team are you working for? What's your role on the team, right? And then if you're walking in with a big group of residents and medical students, introduce everybody, not necessarily by name, but hey, I've got my residents and my medical students today. So an example, hey, I'm Dr. Ghazi. I'm the hospitalist. I'm your primary attending, and I oversee all your care. I'm here with my residents, my medical students today. You might have met Dr. Karpenko earlier this morning. She's my intern on the case. All right, so strong introductions. Then set the time and agenda. This doesn't always work in the inpatient setting, but studies show that when you set the agenda, you have a more efficient patient encounter. I think this works very well in the outpatient setting, sometimes in the inpatient setting. So how do we set the agenda for time? You can actually refer to it. Hey, we have about 15 minutes together today, and I want to be sure to make the best use of it to meet your needs. Or perhaps you're doing your afternoon sort of pop-in rounds and you don't have much time to speak to the patient. You could actually refer to that, right? Hey, I wanted to stop by for a moment to update you. You're letting them know I'm just here for a moment. These are my like pop-in rounds in the afternoon. So you can have specific and non-specific references. But also, how do you create that agenda, right? How do you set the agenda for the encounter? So you can actually just obtain a list. You just ask them for it. Again, this works very well in the outpatient setting. These qualitative data show that obtaining a list from the patients firsthand, right off the bat in the beginning of your encounter, makes your encounter much more efficient. So ask them straight up, hey, I'd like to make a list of all the things you would like to talk to me. Evidence shows patients will on average bring 3 to 5 issues to the table. So you're not putting yourself in trouble by asking for a list, because usually it ends at five items. Okay, so get that list. Don't allow them to delve into detail with each item. Reorient them and stick to the list. So say, hey, what would you like to talk to me about? Let's say, okay, I've got some chest pain that I'd like to talk to you about. Okay, chest pain, what else? Keep asking what else until their list is exhausted and they say nothing more. Now you have your agenda for the entire encounter within the first few moments of your encounter. You already have a patient who feels listened to because you've obtained that list. Now, you don't need to address all those items. Maybe the patient said, I've got chest pain, I've got a noisy neighbor, I have terrible food, I don't like it here, right? You can say, okay, I understand you don't like the food and you've got the noisy neighbor. I'm going to have the nurse manager address those issues. I'm going to deal with your chest pain, your shortness of breath, and your whatever other things, right? And then you can add in your own agenda items, right? So you can add, hey, I also want to talk about the x-ray we did last night and the blood work from this morning. So now you have your framework for how the next few minutes are going to go. You are in control of how this encounter is going to go. And you already have a patient who feels listened to because you got that list out of them. All right, and now using that reference, using that list as a reference, use open-ended questions and ask them, hey, tell me more about your chest pain. Tell me more about this issue, and allow them to tell you their story. On average, a patient will speak uninterrupted. If you gave them no interruptions at all, they would speak on average 60 to 90 seconds. So give them those 60 to 90 seconds, and allow an opportunity, allow them to speak. And as they're speaking, right, show them your attentive listening skills. What are your attentive listening skills? So this is where I like my audience to kind of think of, how do you speak with a baby, right, or with a toddler who's just learned how to speak, right? So imagine, I like to use this example because whenever we speak to little kids, we actually exaggerate those innate listening skills that we have, right? So how do we talk to our toddlers who are just learning to speak? We make eye contact, right? Our eyes are really big, we nod, and we make, maybe we repeat some of the words they say. So of course you don't want to speak to your patient like that. They'll think you're crazy, but I'm just trying to give you a comparison of that spectrum of how we should behave when we're showing our patients that we're listening, right? So silence, don't interrupt them, nonverbal encouragement, nodding your head, using continuers like go on, oohs and ahs, all of those things. Then your reflective listening skills. So as they're telling you their story, hey, I've got chest pain. It goes to my shoulder. Oh, it goes to your shoulder. Tell me more about that. And then at the end, summarize what they've said to you. So I understand you had chest pain, started 2 days ago, repeat their story. Is there more to it? Do I have everything? So these are your reflective listening skills. Now, as you gather the patient's story, you should not only just gather the patient's story, if you can also gather a patient's understanding of it as well. Assess what the patient already knows. These questions actually give you a sort of vision of what social issues they may have in their lives, right? So what have you been thinking might be the cause of your symptoms? Incorporate their opinions, right? What are you hoping to achieve by seeing me today? And then how have your symptoms affected your daily activities? All these questions kind of give you a glimpse into what the patient is experiencing and how this particular condition is affecting their lives. All right, so again, to summarize, we've kind of talked about blocks 1 and 2. These are your bookends in the very beginning, right? So we created rapport, we set the agenda, we got the list, we used patient-centered history building skills, we allowed the patient to speak, and hopefully we have now shortened the clinician-directed history building skills, right? All you have to do now is just fill in the gaps with all the typical questions that we learned in medical school to complete that HPI. Right? Then you would conduct your physical exam, and now we're going to move into educating, counseling, and planning. But before that, we got to talk about how we can rearrange some of the books on the shelf, right? So let's say during this time, a patient responded to you, or a patient demonstrates some sort of emotion, right? They're frustrated, they're angry, they start crying. How many of you have felt that it's a little bit awkward, right? When a patient demonstrates an emotion, you kind of don't know what to say or what to do. Yes? Does that happen, or are all of you very comfortable when a patient demonstrates emotion? It's awkward, right? It's like, gosh, I don't know what to do with this crying patient right now. I don't know what to do with this angry patient right now. I don't know what to say. So when a patient responds with empathy, let's talk about what we do with our body first before we move to the words, right? So let's say you're clacking away on your computer. Are you going to continue typing away? Are you going to continue focusing on the computer? No, you're going to stop, right? You're going to stop. You're going to look at your patient. You're going to make some eye contact. Perhaps you'll change your posture a little bit. You'll change your facial expression, your tone of voice. You might soften it up a little bit, right? You might want to close the space between you and the patient. You definitely want to avoid body language that would indicate a lack of empathy, right? So you're not going to stand there in the corner with your arms folded. You're definitely going to want to unfold those arms. You're not going to be putting your hand on the door handle showing that you want to really escape this uncomfortable situation, right? So approach this comfortably. And then, of course, touch can be powerful if used appropriately. So putting your hand on their hand or on their shoulder, if that's appropriate, definitely would be welcoming whenever a patient's demonstrating any kind of emotion. So this is your nonverbal way of responding to it. What can you do verbally? So this is one of the biggest takeaways from this lecture today. So there are mnemonics that exist out there, and I think the best one is the nurse mnemonic, NURS. This is actually copyrighted by the Academy of Communication in Healthcare. If you actually Google it in the palliative courses, they add an E, NURSE. E stands for explore, but for our purposes, I'm not going to do the E. We're just going to do NURS, the nurse mnemonic. So what does this nurse mnemonic stand for? So N is name the emotion, U is understand, R is respect, and S is support. We're going to practice this. And this is a quartet of statements that you can say whenever you're in that awkward situation where a patient has demonstrated an emotion and you just don't know what to say, right? So let's practice. I'm going to skip this slide. Okay, so I need a volunteer. Everybody in your mind, think of an imaginary patient with an imaginary emotion. They're either angry, they're frustrated, they're sad, whatever it be. Any volunteers? Can I use you? Okay. So you are going to, you can stand right there. Yeah, you're gonna see some text in blue. I just want you to read it out, and then the blank spot, just fill it up with whatever imaginary emotion your patient has. So she is going to demonstrate nursing an emotion for us. Go ahead. That's it. Quartet of statements. You have addressed somebody who's demonstrated an emotion. You didn't solve their problem, right? You didn't make it go away, but you've addressed it, and now you can move on and carry on your agenda, right? Let's do one more. One more volunteer. Yes? Okay. So green text, fill in the blank with whatever emotion, imaginary emotion your patient has. Yeah, that's it. Quartet of statements. You nursed this patient's emotion. You didn't solve their anger issues. You didn't make it go away, but you addressed the emotion, and now you can carry on with your agenda, right? So nursing emotions, I don't want you to take this lightly. Nursing emotions is a life skill. This is not just for your patients. Use it on your toddlers. How many of you have little children? Try this on your toddler when they're yelling and screaming because they want the Skittles under the fridge from 4 years ago. Okay? Try this on your toddlers. They won't know what hit them. Try this on your toddlers. Try this on your moody teenagers when they don't want to come join you for dinner. Try this on your upset spouse. I don't know. Maybe you called your wife fat by accident. I don't know. Try this on your upset spouse. Nursing emotions. This is a life skill. You can use it on your colleagues when they're sad. You can use it on your residents when you're providing them feedback, or your medical students whenever you're sitting down with them and providing them feedback. Anytime you have somebody in front of you who's demonstrated an emotion, it is awkward for a lot of us. We don't know what to say. The nursing mnemonic saves you. You are not solving their problem. You are not making the emotion go away, but you are acknowledging it and you're giving it respect, and then you can move on with your conversation. Now, something I just want to remind everybody, our daily routine, right? We see pneumonia all the time. We see chest pain all the time. We see everything all the time. For us, it's just our daily routine. But for our patients, it is a life-changing event. Coming to the hospital, being poked 5 a.m. in the morning by nurses, having vitals checked, having people touch parts of their body, their belly, their chest that's never been exposed before. These are, having their privacy exposed that way. Having their dignity almost removed from them. This is a life-changing event for patients. And so everybody is walking around with an emotion. So even if our patient hasn't demonstrated an emotion, when you get good with these nursing skills, you can actually pull that emotion out of the patient, right? So when you get really good, ask them, hey, how's everything going for you? How are you dealing with all of this emotionally? They will share with you what that emotion is. And when they get that emotion out on the table, that's your opportunity to nurse it, right? So rather than waiting for a patient to say, oh, I'm sad, or demonstrate that they're frustrated, pull it out of them and ask them questions to get that emotion on the table so that you can nurse it. I like to tell when I do my rotations with my residents, I like to say, like, on a couple of days, I focus on, today we're going to pull out emotions from our patients and we're just going to nurse them. And they think I'm crazy, but after a couple of days, they really enjoy that experience. And it just creates good habits to make it a point to pull out that underlying emotion that every single patient for sure has when they're in the hospital. All right, let's see. Do I have time? Okay, so we're going to talk a little bit about health literacy. So we should know only 12% of the U.S. population is proficient in health literacy, and poor health literacy is associated with poor outcomes. You know, increased hospitalizations, increased ED visits, increased mortality. So it's really important for us to recognize those red flags that show that a patient has poor health literacy, right? So a patient who's non-adherent with their medications, they have difficulty describing how to take their medications, difficulty describing how, you know, their medical problem itself, and patients who don't have questions. These are all red flags as, you know, to poor health literacy. So how can we overcome these challenges? So we should remember that our patients generally have a 4th to 6th grade literacy level. So when we talk to our patients, we should use vocabulary that reflects that. And then we also have to remember stressful times when a lot of things are going on that actually reduces a patient's understanding even further. So always speak in a slow, deliberate manner, frequent pauses, assess for patient's understanding, using plain language, avoiding medical jargon. We know all of this, right? Whenever you're offering new patients, limit it to 1 to 3 items at a time. Avoid the monologue. So how can we change monologue into dialogue? That's another big skill that I want to teach you guys today. So here, this is a sample monologue. If a volunteer can just read this off the board, that'd be great. Anybody? Go ahead.
You also need to take care of your wound, daily dressing changes, from centers home to help you, but you need to do some of this by yourself as well. Also, make sure you follow your care provider next week. Have any questions?
How many of us sound like that? We do sound like that, right? We're like just a train on a track, right? So a lot of us, we do sound like that. I know I sound like that a lot of the times, right? So this is a monologue. We're just talking to ourselves. The patient absorbs nothing. So how can I change this monologue into dialogue? Okay, yes, this is our patient expression, right? When they receive information like that. This is a lot of information for them to download. So, thank you so much. So how can I change monologue into dialogue? So you've got the chunk and check method, right? So imagine all the information you'd like to share with your patient, it's a big pineapple, right? We're never going to shove an entire pineapple down a patient's throat, right? We're going to cut it up into nice bite-sized pieces. You're going to pick up a piece, you're going to explain it, you're going to hand it over to them, and they're going to eat it. And then you will make sure that they ate it well, right? So pick up piece by piece. So each information you offer to the patient shouldn't be an entire pineapple, they should be pieces of the pineapple. So when you think about what I need to share with my patient, think of them in your chunks, right? Think of them in chunks. Now, what else can help you with this? This conversational tool, it's called the ART loops, and the ART stands for ask, respond, tell. So anytime you want to share information with a patient, change it into a question. Ask the patient, have them respond with empathy, and then tell your perspective. So now we're going to change that monologue into dialogue. I'm going to need your help if you don't mind. So wherever it's italicized, I just want you to read that out. Okay, so I'm the physician. I'm changing my monologue into a dialogue. Right? And then we're going to make these what we call ART loops. So that entire monologue changes into ask, respond, tell, ask, respond, tell, ask, respond, tell, just a loop after loop after loop. So let's go ahead. I'm going to ask the patient, hey, what do you know about using antibiotics? Correct. You're going to be discharged on an antibiotic called Keflex. It's going to be for 7 days. It's basically the same medicine we've been giving you by vein, but now you're going to take it by mouth. That is one ART loop. Now my next point, I'm going to turn it into a question. What is your understanding about your wound care? That's right. We will provide instructions on how to care for your wound. So those are 2 sample ART loops, right? So again, every point that you are trying to share with your patient, change it into a question, get their perspective, and now you have dialogue, right? And actually, look, my patient already knows the nurse is going to go home to help them. And, you know, the social workers probably already told them that, hey, you know, we're going to send a nurse home to help you. So by them sharing information they already know actually helps you save more time because You already know what your patient knows, right? So you don't have to waste time repeating a lot of the information. So that's your ART loop. Now we can use ART loop when we provide teachback, right? So what is teachback? Teachback is when you explain something to a patient, you assess how much they know, you clarify a little bit, and you keep assessing, clarifying until they have full understanding. So whenever you provide discharge instructions, how can I incorporate these ART loops into my teachback? So you can just ask them, right? Can you tell me in your own words what we've talked about so that I know I did a good job explaining? So let them repeat what your discharge instructions are. You respond with, respond to them and then tell them any additional points. Another way to ask them in terms of teachback, you can ask them, hey, when you speak with your family member, what are you going to tell them we discussed? So give them that opportunity to repeat to you what they've learned and then tell them any additional points that they're missing. So that's how you incorporate ART technique into teachback. Now we're going to close our encounter. How can we do this? Allow for questions. So I like to say, don't ask them, do you have any questions? What's wrong when I say, hey, do you have any questions? Anything wrong? Yeah, right? Because when you ask them binary questions, it kind of almost seems like, hey, I don't want to really be here, so do you have any questions so I can leave, right? And then their only answer can be yes or no. And oftentimes patients don't want to seem stupid, to be honest, right? They think that if I ask questions, the doctor's going to think I wasn't listening. So instead, assume they have questions. They have to have questions, right? So use an open-ended statement and say, hey, what questions do you have? What questions can I answer? Make sure you encourage them to ask questions. And remember, not asking questions is a red flag for poor health literacy. So then in those patients, demand it from them and say, no, ask me 2 questions. I want you to ask me 2 questions. And the questions they ask actually gives you a perspective of really how much they really understood. And maybe this patient needs a little more explaining before they go. And then summarize your next steps. This is a very good exit strategy. Sometimes you get those really friendly patients who just, it's so wonderful. You want to stay around and talk forever, but you just can't. So this is a very good exit strategy. It's the I do, you do method. So, hey, I'm going to go put that discharge order in. I want you to go call your family members, let them know what time to be here, right? It's the I do, you do method. Or it could be, hey, I'm going to go tell the nurse that you're ready for your whatever. Why don't you do so-and-so? So it's the I do, you do method. It's a nice way to exit a nice conversation, and you can start taking your steps backwards. Make it personal before you leave. Provide them with a practice brochure if you have one, or a business card. Have something tangible for them to know, like, okay, this doctor was in my life for 5 minutes today, right? Write your name on the board. You should not be GenMed 6 or GenMed 7. That should not be your designation. Your name should be on the board. I don't know. I'm assuming we use whiteboards here too, right? So your name, you should have a whiteboard marker in your pocket, and you should be writing your name on all your boards. And then shake hands. Again, post-COVID, many of us don't want to go back to that, but it's always a nice thing to shake hands with the patient. And then, of course, end with a thank you. Thank the patient. Then demonstrate some coordinated care. Put a name on it. So again, we already talked about identifying yourself, put your name on the whiteboard, use business card, but also when you refer to other people, right? So when you say, hey, I'm going to tell the nurse to come in and check your blood pressure. No, say the name. The name should be on the board, right? It should be updated. And if it's not being updated, we should talk to whoever's in charge of the floor to make sure nurses are updating their names. So say, hey, the nurse Anna, I'm going to let her know that, you're ready to get your next vitals checked, or whatever it is you're talking about, right? So don't say, hey, the nurse or the social worker or the care manager. Use their names, right? You know your care managers. You know the social workers. You just rounded with them in the morning, right, for multidisciplinary rounds. So you know who's in charge of their case. Use their names. This really shows that we have coordinated care and we're a cohesive team. Even when you're talking about your colleagues, right, or your consultants you're bringing on board, hey, I'm going to ask the cardiologist to see you. If you know the cardiologist's name, use it, right? And even when you're talking about patients' family members, instead of saying, I spoke to the wife, right? No, I spoke to Anna, your wife, on the phone, right? So use names. It just puts a separate type of respect and dignity to it. And then actually do follow up with communication. If you are going to say, hey, I'm going to tell the nurse, actually follow through and let the nurse know. So whether it's verbally communicating, secure chatting, communicating even amongst the staff members, helps with better communication with the patient. They're all connected. Consider, for complex situations, difficult patient situations, tell the nurse to join you when you round, right? Calling family members. There was a little, like a mini sort of QI project we had done a couple of years ago, not at Loyola, at a different hospital where I worked at. We would actually call family members in the room. And a lot of the patients felt that physicians were spending more time with them, and you're actually killing two birds with one stone, right? You're updating the family members, but you're updating the patient as well. So you're not doubling your work and having to go back to your office and making separate phone calls. And then consider, for, again, those complex patients where there's a lot of things happening during the day, pop in the afternoon, do your pop in afternoon rounds and give them that moment to update them with what's going. Maybe you can't physically go to the room, but call their room, right? And then play up your colleagues. When we talk about this in eye care, we use the terminology manage up your colleagues, right? So whenever there's transition of care or you're going to talk about a separate colleague, play them up a little bit. So what are examples of how we can do that? So we can talk about our social worker. Hey, I know our social worker, Anna, she's trying her best to get you to the rehab of your first choice. Great. You just played her up a bit, right? Or you can talk about perhaps your service is ending and Dr. Smith is going to take over, right? Hey, my colleague, Dr. Smith, is going to be taking over from tomorrow. He is great. He's going to take great care of you, right? Or similarly, you may have just taken over this patient from the nocturnist or from the previous attending, right? Hey, you were admitted by my colleague, Dr. Baker, last night. She's told me all about you, right? So just putting a positive spin to wherever, well, not spin, because then it looks like you're trying to change fact, but just putting a positive, few words to whenever you refer to your colleagues is great. And the whole purpose is for your patient to feel well taken care of, that, hey, I've got a cohesive team that's communicating with each other, taking care of me. I'm going to skip through this, but I'll just mention briefly, prior to coming to Loyola, I had a hospitalist group who really had a lot of trouble getting patients to understand that they were the main doctors in the show. Patients just didn't understand what a hospitalist was. And so we actually went through scripted introductions, scripted closure, scripted follow-up statements, and they were able to actually improve patient experience scores by having these scripts. So just so you are aware, scripts exist out there for struggling groups who are not really able to make that connection with their patient population. All right, so what is our education plan? What is this curriculum all about? If within this audience, if anyone is drinking the Kool-Aid I have just offered you, if you have found, if you feel like this is something you would enjoy and would love to be a part of, contact us. We're looking for volunteers. We're looking for, communication champions who would love to spearhead this project. And we meet regularly every month, every other month, and we come up with different ideas and ways to share this information and teach these skills to our colleagues. What we're doing for this particular curriculum, we've divided the skills into the blocks that I showed you earlier. And each month we target one block. We cover one block, and each of those blocks covers a few of those skills. So each week, you would be covering a particular skill. So for example, when we talk about block 1, which is creating rapport quickly, perhaps week 1, we're all focusing on shaking hands and providing strong introductions. Week 2, we're all focusing on sitting down. This is the week we're all going to be sitting down. Week 3, we're all going to be providing small talk before big talk, so we all share our experience. We all do the same thing. And the idea is to slowly but certainly create better habits and permanent habits, and ultimately improve our patient experience. And yeah, this is an example again of the different blocks that we have. This is a little bit about eye care. I think Anita can share with us in a little bit. Yeah, and these are your contact people. So my name's up there, Sadia Ghazi. Here, Dr. Beret at McNeil, and then Dr. Kazi and Dr. Bertino at Gottlieb Memorial Hospital. We are your contact people. So anybody who feels like, no, this is something I too am passionate about, I would love to be part of a project like this, contact us. We would love, as many volunteers as we can get. Now, if you have not learned anything from this 1 hour, because I know there was a lot of information, just remember this wonderful character from The Princess Bride, my favorite movie. I've probably watched it a million times as a child and even into adulthood. But this is my favorite favorite character who gives perfect demonstration of how to create rapport quickly. So he says, hello, right? Your welcoming statement. My name is Inigo Montoya. Strong introduction. You killed my father. Personal connection, right? And then prepare to die. He sets the agenda. Great. So that's your key takeaway. Any questions? I do have Anita from Patient Experience, and she might do. You want to do like a 5-minute thing? So she'll probably share some data with you on, our patient experience scores. But yeah, any questions? I'm open.
Dr. Kazi, this is Dr. Dudani. I'm the attending physician at McNeil. Thank you. It was an awesome lecture. I think we still continue to learn our communication skills. We have led health literacy project on an outside, we've actually done a lot of education for our residents on health literacy, and we have done our QI project on health literacy as an outpatient. And I think our next step is actually connecting with you to see how we could do this quality improvement initiative on the inpatient side, because that's what Dr. Barry suggested us on our research day, that we should move towards a model and utilize eye care and these communications. So we do have a team of health literacy, and we would love to connect with you to see how we could do that on our inpatient side and inculcate these communication skills for our learners.
Oh, yeah, that's awesome. Yeah, so please definitely email me. I'd love to know more about what you guys are doing. And I'm sure incorporating eye care and a lot of this curriculum, we can definitely make this more fruitful.
Thank you.
Yeah. Yes.
He seemed frustrated or angry. And he came back with, well, duh, going through everything that I've been going through, you're frustrated too. And he sort of, found it in a negative way.
Yeah.
And I just kept listening and didn't really respond to that comment. And I just wondered, like you said earlier, don't ask how you are. I just wondered, some of the pitfalls of trying to nurse.
Yeah.
If you could talk a little bit about that.
Yeah, absolutely. So first of all, I think the nursing statement is effective when all 4 components are together, right? That quartet of statements. So asking, hey, I can see you're frustrated alone will probably not go anywhere, but to follow it up with, obviously listening to a story, but saying, hey, I can see that you're frustrated. Understand it. Gosh, I would be frustrated too if I were in your position. Respect it. Thank you. Thank you so much for sharing this with me. This is very important information for me to know. And then provide that last support. So I think when we do that nursing statement, having that quartet all together is oftentimes helpful than just perhaps acknowledging it on its own. Yeah, rather than just naming it, to follow it up with the other components of that nursing statement helps to just wrap it up, because they want that acknowledgement, right? And they want that understanding, and they want you to show that, yes, I understood that you're frustrated. I'm not solving your problems, but I'm giving you that respect that you should be frustrated, what you're going through. And then similarly about the asking questions, again, we should ask questions, just not in that initial introduction, right? Because what would happen if I walked into this patient's room and the first thing I did was, hey, how are you? He would have been like, I'm pissed off because da 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 da. And we don't want that yet. We want that in 5 minutes, but not right then. We want to walk in and just give him our introduction. We want to do a little bit of small talk. Maybe we'll be a little angry and frustrated, but at least we'll get that opportunity to make things a little more warm and mellow before we dive into these questions, which ultimately, and you would sense perhaps that, hey, there's stuff going on in this room. Patient doesn't seem, very happy with things. And if you follow that protocol, that information will come out and you will get an opportunity to nurse that emotion. So I guess that would be my answer to your question. Yes.
I think one thing that I've answered that, because understand is that, I understand how you might feel this way, but I would avoid, I understand how you feel, because
Yes.
that's a different statement, and you usually don't understand exactly how they.
Correct. Yeah, and actually when we do this in our palliative course, we actually do make this point. Because when you say I, you actually change it and you make it about yourself. So that's actually a very good point. And so these are all things that come up. And whenever we have our little patient experience gatherings and meetings, people will share. Residents will often tell me like, hey, I did this nursing thing. It worked awesome. But in this particular episode or this particular situation, this happened. And we all learn from that. So that's actually such a good point that by saying I, you actually turn it and make it about yourself, and it's not about yourself, it's about the patient. So thank you so much for sharing that. Oh, see, I nursed your emotion. I said thank you so much for sharing that. All right. Any other questions? Yes. So you're saying the particular patient who wants time, you can't give much time to this patient because a different patient is sick. Yeah. So when I have patients like that, what I will do, this is actually where that list thing comes in handy. So I say, okay, what are your frustrations? Share with me. Give me your list. And they'll say the food is bad. The neighbor was noisy. This happened. They poked me too early. They poked me too late, or blah, 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 blah. Get that list and then reallot the response, because you're the doctor. You're not supposed to be the magician here solving their problems, but you acknowledge it, right? And you say, okay, this and this and this, I'm going to tell the nurse manager right away, and let's see what she can do or he can do to help situate it, right? But assigning a designee for each problem that they're saying and making sure that they are aware, like, I get that you are frustrated about this, but I can't help you with this, but I'm going to figure out who can, right? Does that kind of answer your question? So getting that list from them, saying, hey, tell me what your frustrations are, listening, get that list out of them, and then allotting those responsibilities to whoever would actually solve their problem. And then taking care of whatever emotion they're demonstrating. Again, the nurse mnemonic, it's not supposed to solve anybody's problem. It's not supposed to remove their frustration, but it's just supposed to give them that second of feeling of validation and that you can kind of get over that emotional bump. And usually after you do nurse their emotion, you will notice your patients, they will stop demonstrating that frustration or they will stop demonstrating that sadness because you've acknowledged it. And I think it's really that search for acknowledgement that makes them keep complaining and saying the same thing over and over. So that has been my experience, that when you acknowledge it with this kind of nurse approach, then they stop continuing with the frustration or continuing with the anger. And then getting that list and telling them, hey, I'm the doctor, but I'm going to have this and this addressed by the nurse manager. And then tell the nurse manager it is their responsibility to figure out a lot of these things. I don't know if I answered all your questions. Was there another thing? Okay. Yeah. Okay. So then give them like an agenda, right? So tell them, like, sir, I know I did have just a moment to spend with you, but I will come back. I do have a different patient that I need to see who's pretty sick right now, but I understand you are frustrated and you have every reason to be frustrated. Nurse that emotion and give him a plan, give him the agenda, right? And say, I will come back and we'll talk more about this. Please keep a list ready of what you want to talk to me about. Give them some importance. But, I think just explain your situation and be honest, I think is okay. Hmm.
I think it helps to
if there is a truly emergent situation going on, saying things like, hey, I'm getting a message about an urgent situation. Let me do this about this issue and come back and talk to you.
Yeah.
Because and then, but you have to, you're committed. You
Right.
have to go back, because then you kind of, if you don't go back, then you really,
Right.
you're,
Yeah. Yeah.
I was just wondering if there's like a specific tool to use in that situation, because generally, I would say something like, it's really important that we, address this. I want to give it the right amount of time, but, I want to let you know that I have this other situation going, and I do want to make sure that I don't leave that patient who's pediatric. Make sure it's accomplishing training. But I've had that, not function.
Right. And it's almost like that I do, you do exit method, right? Be like, hey, sir, I have a moment with you to spend, but I have got to do this. But you know what? I want you to do this for me, and I will be back. Follow up with what is your potential next solution. And then truly do follow up, because you don't want to completely damage that rapport you've created. Yes.
Mapping it out. It's very similar. Because, in phase the A is affect, and that's naming the emotion. What's troubling you the most, that's the T, is sort of understanding, what it's like for them. And then how are you handling it? And then the E is actually empathy. So that empathy is the support that is in nurse. So it's essentially the same. Just
Very good.
Yeah.
Okay.
Because
Yeah.
I think that's what ever since that HF practice, I've in various situations, not just in women's.
Yeah.
I have found that with my husband.
See, it's a life skill. It's not just for patients. It's a life skill. But yes, definitely try nursing emotions on your colleagues, on your at home, your family members, your parents, your children. It is a life skill. It is a beautiful way of communicating with whenever someone demonstrates an emotion. That's it. Okay. Thank you. Awesome. Yeah. Okay. No, that's not mine. Oh, nice. I'll take the warm one. The cold one. Yeah. Thank you. Hey, how are you?
How are you?
Oh, nice to meet you.
Ali speaking like me.
Oh, so funny. Yeah.
We've been listening to
Yeah. Oh,